Good morning, everyone. Today, we'll be presenting the resident presentation from the Department of Interventional Radiology. We'll be presenting three cases, and I'll be presenting the first case. So the patient is a 34-year-old male who had no comorbidities, and during workup for inguinal hernia, patient was incidentally diagnosed with EHPV. So, uh, there were multiple episodes of abdominal pain since 2006, for which the patient was taking over-the-counter medications. At the current presentation, the platelets were a bit low, 60,000, TLC was 1.7, and bilirubin was elevated 1.3. This is the baseline CECT on September. In this, we can see that the portal vein is completely replaced by a cavernoma, and there is splenomegaly. And this is the coronals showing the same, that there is formation of portal cavernoma and splenomegaly with minimal IPRD, which was suggestive of EHPV. There was also chronic calcific pancreatitis. Mm, We can see that the pancreas is atrophic with dilated MPD and parenchymal calcification. So this was the final diagnosis, EHPVO, with portal hypertension. There was chronic calcific pancreatitis and a right inguinal hernia. There was a past history of 2 episodes of hematemesis for which EVL was done. So for this, patient underwent splenectomy along with a proximal lienorenal shunt, along with right inguinal mesh gonoplasty. On post-op day 12, patient had persistent high-grade fever for which CCT was done. And in this, we can see that there was thrombosis of the retropancreatic splenic vein with the thrombus extending into the splenorenal shunt. And these are the coronal images depicting the same. This is the thrombus in the lienorenal shunt. And patient had an elevated TLC of 20,000. So for this, the patient was planned for shunt thrombolysis. For this, we took access from the right common femoral vein, and then we inserted the catheter into the left renal vein, and we tried to cannulate the lienorenal shunt. We attempted to cross the thrombosis with the Teremo. However, despite multiple attempts, we were unable to go upstream to the thrombus. And during manipulation, there was a localized extravasation of contrast as well in the perinephric space. Following this, decision was taken to abandon this procedure. And after consultation with the surgical team, as the portal venous radicals were patent on ultrasound, the native portal vein radicals were patent, and they were communicating with the native residual portal vein. A plan for a percutaneous portal vein balloon angioplasty was done. So this is the initial spot after puncture of the portal vein percutaneously, and this is the opacification of the portal venous radicals. And then this is the run using the NEF set, and you can see that this is the portal vein which is opacified. However, the proximal part of the portal vein is not opacified. So then we negotiated using a J-tip Teremo wire, and we were able to cross the obstruction. And this is the run. This is showing the SMV. This is showing the splenic vein. However, the portal vein is not opacified, and there is opacification of collaterals. This is again a run from the SMV showing similar findings. The main portal vein was not opacified, and there was opacification of collaterals. So following this, serial balloon dilatation was done with 7 mm balloon, followed by 10, followed by 12 mm balloon. You can see that this is the waist at the site of the narrowing, and here after complete inflation of the balloon, there is no waist. Following this, run was taken from the SMV. We can see that there is now, after injection of contrast from the level of SMV, there is a opacification of the portal vein, which was not seen earlier. However, there is some amount of narrowing still persistent at the place where ballooning was done. So a decision was taken to deploy a uncovered stent at this level. And here we can see that stenting was done, following which there was significant improvement. Good flow was achieved through the stent. However, some amount of filling of collaterals was still seen. Subsequently, when we repeated a run from the distal SMV, we saw that there was complete thrombosis of the shunt was seen, and there was no filling of the intrahepatic portal venous branches. And when we took a run proximal upstream to the stent, we could see that the intrahepatic portal vein was patent, which was suggestive of thrombosis of the stent. Following this, another uncovered stent, a longer stent, 8 centimeter stent was deployed within the previous stent. And this was the run from the SMB. It was showing good opacification across the stent. The intrahepatic portal vein branches were opacified, and there was no filling of the venous collateral. Post procedure, there was decrease in the drain output. There was a single episode of fever due to thrombophlebitis, for which antibiotics were given, and the patient was afebrile and was subsequently discharged. TLC normalized and bilirubin also normalized. Patient was on ecosprin and dabigatran, and 1 week follow-up ultrasound, it showed that the stent was patent. So portal vein recanalization, it is done for typically can be done in isolation for chronic non-cirrhotic EHPVU. For recanalization of chronically thrombosed and or fibrosed portal vein, it relieves the portal hypotension, leading to disappearance of the collateral channels and resolution of portal biliopathy. So in this case, we wanted to highlight that initially we had planned for thrombolysis of the thrombosed renal shunt. However, as we were unable to do it, then a decision was taken for portal vein recanalization, as it was feasible because the native portal vein radicals were seen and there was no ascites. So in this challenging case, then that was done, which and subsequently the stent was patent and the patient is currently on follow-up.
It's like in 1 month.
The literature, what is the long-term follow-up data?
So,
These
so the data suggests that it is very good for non-cirrhotic EHPVU. Those cases in isolation, PVR is it remains patent and it is a good technique when feasible.
You should have got some data. Okay, yes. You have got some data. So, sir, in this case, actually, there was a case of EHPVU which was already undertaken for surgery, where splenorenal shunt was reconstructed. So, actually, the plan was to recanalize the surgical splenorenal shunt which they have created, which thrombosed in a post-operative period. But since we failed, we just tried that, okay, we need to restore the hepatic flow. Can we do it naturally? So we are trying this. This is a new procedure which has been described in the last 5-7 years, where portal vein recanalization. So initially for EHPVU, PVR tips was advised in a decade, about a decade back, 2015-16, when the concept came of portal vein recanalization tips. This is how it started, that how can we treat EHPVU through interventions. Then there was another group from Europe which started that why do we need to do a tips? Why can't we just recanalize? So the data available is available from only 2 centers from Europe, and it is very small. So about 30 to 40 patients, but they have a follow-up of around 5 to 7 years. So overall, if we see, these are good procedures to begin with because the portal vein was already thrombosed and the stent is placed exactly at the site where thrombosis was present. So in case it thromboses, it will thrombose the stent, which was the thrombosed. So only drawback is putting a metal in that area. Otherwise, it is relieving the complete system and restoring the normal anatomical and physiological flow within the human body. So that is the concept. So we are just trying. We have done around 10 cases till date, but overall follow-up is good. This patient we did about 2 to 3 months back. But I feel, if I remember correctly, we have done around 12 cases. And the last we did was about 3 years back. All have a patent portal. But long-term data still needs to be seen. We are still not sure. They are on an anticoagulant. We'll come back with this paper.
Good morning, everyone. So to begin with my case, here is a 25-year-old male. He was a non-smoker, non-alcoholic, and he presented with 3 months history of loss of appetite, weakness, fatigue, and failure to gain weight. He had no history of any fever, jaundice, abdominal pain, hematemesis, altered sensorium, or decreased urine output. Uh, in the past, he had a single episode of pleural effusion and ascites at 12 years of age, and he was evaluated outside, and he was empirically started on ATT, which he discontinued after 4 months. And in between time period, he was essentially normal, and he underwent outside ultrasound at 25 years of age when he was at 25 years, which showed presence of portal cavernoma with dilated intrahepatic biliary radicals and splenomegaly. So he was referred to ILBS for further management. These were his baseline laboratory investigations, where we can see there is reduced TLC and platelet counts, and bilirubin levels were mildly increased, and without any significant, and rest of the lab parameters were essentially within normal limits. On further workup, his viral titers were non-reactive, and his coagulation profile, which was done twice, were normal. So he underwent an upper GI endoscopy, which demonstrated large high-risk esophageal varices with red color signs showing imminent risk of bleeding, and he also had mild portal hypertensive gastropathy. So a CECT whole abdomen was done. These are the axial contrast enhanced images in the venous space. On scrolling craniocaudally, we can see this is a non-cirrhotic liver, and grossly we can appreciate that there is some mild to moderate high HBRD present, and the portal vein is completely replaced by periportal collaterals forming a cavernoma. And we can see there is some peripolicystic collaterals as well, and the spleen is grossly enlarged with dilated splenic vein. On further scrolling, there was no other any significant gross abnormalities in the rest of the solid abdominal organs, and also there was no ascites. These were the coronal sections. Here we can see a non-cirrhotic liver with portal cavernoma and some IHBRD and splenomegaly notice. And here we can see this is the calcifications. This is a native portal vein which is chronically thrombosed, and the wall has developed calcifications within. This is the native portal vein. So this is a young patient with a non-cirrhotic morphology and having features of portal hypertension like splenomegaly and having high-risk esophageal varices. So this was a clear-cut case of EHPVO with portal biliopathy. The patient was not in cholangitis, and there were no any other comorbidities. So we decided to manage this patient with portal vein recanalization and stenting. So since his coagulation parameters were normal and there was no ascites, we went ahead with percutaneous route. Using a micropuncture set, we punctured a peripheral portal vein radical. And here we can see this is the dichotomous branching of the portal vein visualized. And after a series of multiple attempts, which took us around 15 to 20 minutes, we were finally able to negotiate across this chronically thrombosed portal vein and enter the splenic vein. And run taken from here, we can see there was only filling of periportal collaterals or cavernoma with no obvious visualized any other intrahepatic portal vein radicals. We can see only the cavernoma is getting filled and no opacification of intrahepatic portal vein radicals. So balloon dilatation of this thrombosed portal vein was initially done with 8 and then 10 mm balloon. Here we can see there is narrowing formation of a waist. Here we can see post dilatation there is the disappearance of this waist, and since there was some residual stenosis present even after balloon dilatation, we went ahead and planned to put a stent. An uncovered stent was placed across this chronically thrombosed portal vein. Post balloon dilatation and stenting, we can see the intrahepatic portal vein radicals are starting to appear, and the flow within the cavernoma was very sluggish. So this is a single shot image where we can see the stent placed within the portal vein, and the access tract was embolized with Amplatzer vascular plug. So post-op, post procedure, the patient was started on injection Clexane, and after 2 days, it was switched over to acetron. However, this was a technically successful procedure. However, from the post-op day 2, we started noticing there was elevation in the bilirubin levels. Here we can see these were baseline where his bilirubin levels was 2.3, and from the day 1, it was 4.8, it rose to 6, and then it increased to 9. However, in view of increasing bilirubin, we did an MRCP, and then he was planned for ERCP stenting. These were the MRCP images. We can see some mild dilatation of intrahepatic biliary radicals. However, there was no any obvious obstruction noted within the bile ducts to cause this increasing bilirubin levels, which was unexplained in the post-procedure period. So ERCP stenting was done. However, post ERCP stenting also, we noticed that there was elevation in the bilirubin levels from 9 to 15, and suddenly it jumped to 25. So a second CT was done at this point of time. Here we can see this is the native portal vein, which we did portal vein recanalization. We can see the stent has been placed, and there is wall-to-wall contrast opacification seen within the stent, and the periportal cavernomas have decreased in number. However, there was no any other obvious cause to explain this rising bilirubin levels. So we considered a possibility of a biliovenous communication, which was causing this increased bilirubin levels without any rise in any other laboratory parameters. So a remote possibility of bulimia was considered. Since we had accessed this portal vein through percutaneous access, we first initially went ahead to close this small biliovenous fistula, which was not identified on MRCP or CT images, with percutaneous glue embolization of the tract. So the tract embolization here was done with the help of glue. This was post day 6 where we did tract embolization of the glue with glue, and then even after that, we noticed that there was bilirubin, sharp rising bilirubin levels. It went up to 34. So it was where we noticed that we were not able to close this small biliovenous communication with the help of tract embolization. So the right hepatic vein, which was coursing along this percutaneous access tract, we decided to obliterate this, embolize this right hepatic vein, which was coursing along the percutaneous tract. So here we can see we took transjugular axis and entered the right portal vein, and we took a run, and we can see this is the right portal vein which is getting filled, and we placed an and we decided to embolize with blue. And here we can see the right hepatic vein is completely embolized with blue. On following day, the bilirubins started to decrease, and we can see bilirubin values decreased from 34 to 28, and within 48 hours, it decreased to 15. And the patient was discharged in stable condition. And at 3 months follow-up, there was good flow through the stent, and the bilirubin levels were reduced to 3. So to touch upon this concept, bulimia is a rare, but it is a potentially lethal condition representing abnormal communication and flow of bile into the bloodstream. Communication can occur after liver trauma or any procedures which are carried out on the bile ducts or liver. And the most common form of this is hemophilia, which describes where the blood flow, the flow is from venous or arterial blood into the bile ducts, since venous and arterial pressures are generally higher than the biliary pressure. Normal pressure in hepatic vein is around 0 to 5 mm Hg, and in the common bile duct, it is 10 to 15 mm Hg, and in the hepatic artery, it is 100 mm Hg, and in the portal system, it is 10 mm Hg. In cases where there is elevated pressure in the bile duct system over the hepatic venous pressure, the flow of bile into the liver vein can occur, and this condition is referred to as bulimia. Normally, the gradient which is required so that the bile enters from the bile ducts into the bloodstream should be more than 10 mm Hg. If the gradient is less, it will spontaneously close. The fistula spontaneously close, and many such communications flow spontaneously due to slow flow through biliovenous fistula and may never be diagnosed. So bulimia becomes significant when there is a considerable amount of bile enters the bloodstream. Usually the obstruction of bile outflow with bile duct dilatation is the reason for bulimia. Our cases of bulimia without bile duct dilatation have also been reported. Bulimia can cause more severe conditions such as hemolysis, biliary sepsis, and the dreaded pulmonary embolism. So we have to treat this condition. It is most dangerous when a large amount of bile suddenly enters the bloodstream and acts as an embolus in the lungs, potentially causing sudden death. If bulimia does not resolve with conservative treatment, there are surgical, endoscopic, as well as percutaneous treatment procedures which have been described. Coming to some endovascular techniques, percutaneous embolization, where we'll close the biliovenous fistula with either coils or liquid embolics or fibrin sealants. Coil embolization is often attempted first, but if liquid embolics can also be used if coils are insufficient. So another concept is biliary drainage or decompression, where bulimia occurs due to raised bilirubin intrahepatic biliary radical pressure. We will try to decompress this uh, uh, biliary system so that the fistulas will spontaneously close. So PTBD or ERCP can be done in these patients as we did in our case, but still uh, the rising bilirubin trend was observed. Another treatment option is endovascular stenting, where particularly when bulimia is associated with the trauma and there is significant vascular injury. And also we can use a combination of these methods where ERCP and percutaneous radiologic interventions to maximize biliary decompression and facilitate spontaneous closure of fistula. The iatrogenic causes which are described in the literature for bulimia are following transjugular or percutaneous liver biopsy. Even can be seen after post-TIPS procedure, percutaneous after PTBD and after percutaneous liver ablation. The reported frequency of biliovenous fistula is less than 0.1%. So this makes it a unique rare presentation. And also endovascular embolization is reported to be technically effective in up to 75 to 100% of published cases, often allowing immediate resolution of bulimia and avoidance of major surgery. So this is one case from the literature where we can see this is a large right lobe mass, which was a cholangiocarcinoma. They did a percutaneous liver biopsy, and post liver biopsy, there was rise in bilirubin levels, which was unexplained. So they did a percutaneous initial cholangiogram, and there was communication seen between the biliary radical and the middle hepatic vein, and they embolized it with coils. However, it was insufficient, and still the communication was existing, and so they decided to embolize percutaneously only the hepatic vein around the site of percutaneous axis. This is one more case where the internal external PTBD catheter has been placed, and the run took from it, we can see there is communication between left hepatic duct as well as the left branch of portal vein, and there was a broad-based communication present between the two. So they decided to manage it with placing a covered stent across this fistula site. And post placement of a covered stent, we can see there was no opacification of any portal vein radicals. So to conclude, bulimia is a rare but potentially lethal condition that occurs when the pressure in the bile ducts exceeds that of venous system, resulting in extremely high levels of serum bilirubin. ERCP with endoscopic sphincterotomy is an effective modality for managing this potentially lethal complication by decreasing the pressure in the biliary system. However, in failed cases with ERCP, percutaneous or endovascular management with coils, glue, stent placement are some of the other potentially available options to manage this biliovenous fistula. Thank you.
Another interesting case, I think, here, ERCP was also attempted, but that did not help.
This is the second case which we have seen. So it is a very, very rare thing because mostly venous or arterial pressures are higher than the biliary pressure. So flow is mostly the blood flows from the venous system to the biliary system. Rarely we see the opposite, that bile flowing into the bloodstream. And this is what happened. And actually, this is a diagnosis of exclusion unless until it is a very big fistulous communication, because you generally don't see it in any imaging. So first you rule out everything and then you come to the diagnosis. Okay, fine, we have ruled out everything. And now probably this is the only thing. And then you will have to find the site. So for us, the site was again a challenge, but fortunately we had placed a plug while coming out. So this is another case like that we showed the first one that was also portal vein recanalization. This is another case which we did a portal vein recanalization for EHPVO. While coming out, we placed a plug, but despite placing that plug, it was unable to close that communication between the small bile duct radical and a hepatic vein radical. And that led to continuous rise in bilirubin. We tried to put some glue percutaneously, again we failed. So we went deep into the right hepatic vein and embolized just the distal part of the right hepatic vein so that any communication between two is closed off. And it worked. And this kid is from Jabalpur, and it's almost 4 or 5 months. So he keeps sending me the reports. The reports are absolutely normal, and his cavernoma is totally gone. I think you missed the CT or the cavernoma. Now there is no cavernoma. So there are two messages like EHPVO. In some of the cases, we can recanalize the portal vein as we do in Budd-Chiari syndrome. And while doing such procedures, there are chances that these rare complications may occur. So we all need to be aware of these things and act accordingly as a team. So first ERCP or PTBD should have been done, that we did, to reduce the biliary pressure so that any pressure, if there is a high biliary pressure, it should stop leaking into the bloodstream. But that didn't work in this case. So ultimately we had to ambulance. So there are only few cases in literature, and he has shown that. But this is one of the interesting cases. I think this has already been accepted for publication. So we had sent it for publication, and it has been accepted for publication. The everyday rising, sir, it has gone up to 34 bilirubin. And it's just in the previously when the patient came, it was just 3 to 6, 6 to 8, 8 to 12. And gradually you can see the trend. Sudden. So day 1, 4.8, day 2, 6.9, day 3, 8.9, day 4, 9. So you can see day 7, 34. So in 7th day, and isolated rise, no AST, ALT, SAP, GGT, everything remains normal. So that's the thing. Why there is an isolated rise in bilirubin with the rest of the parameters being normal, albumin being normal, no ascites. So these are the things how we suspect, only rise in bilirubin.
Good morning, everyone. I would like to present the third and the final case from our IR department. My patient is a 51-year-old male, and he has presented for the first time in December of 2024, where he was diagnosed with ACV-related chronic liver disease. And for the same, he received antiviral treatment and achieved viral clearance. Subsequently, in the same year, he developed abdominal distension. He was evaluated, and he was diagnosed with multifocal hepatocellular carcinoma. Our patient presents now in 1 year later, that is in 22nd of December in 2025. He presented in the emergency department with melena and abdominal pain. There was history of jaundice for 1 week and a 3-day history of hematemesis, which the patient provided. And on the vitals, the BP was 91/63, and the pulse rate was high, 124 beats per minute. The respiratory rate was 20, and SpO2 was maintained. There was no history of fever, any altered sensorium, or decreased urine output, and no previous history of diabetes, hypertension, coronary artery disease, TB, COPD, or any thyroid disorders. Following which, we sent the routine investigations, and the hemoglobin was found to be very low. It was 6.6 gram per dl, and with a high TLC level. The viral serology was negative. Liver also showed a very high AST/ALT levels of 658 and 189 units per liter. Tumor markers, as the patient is a diagnosed case of HCC, were found to be high, with PICA being 1236 and AFP being 417. Subsequently, on the low hemoglobin and the vitals, patient underwent a CT scan and the endoscopy. On CT scan, we could see that there is a tumor thrombus in the left portal vein here. And also the main lesion is in infiltrating HCC is in 6 and 7. on other sequence, other slices, we can see that it is extending to the left portal vein coming towards the main portal vein. And this is the right portal vein showing the same tumor thrombus. And we can also see some enhancement within it, which is like a streaks pattern of enhancement, which is typically found in portal vein tumor thrombus. And this is further extending, as we can see, into the main portal vein, reaching up to the confluence. This is the sequence in which we can see this is the main tumor, and this tumor is extending the spine vein. And there is also ascites, and CT scan reported that this is an infiltrating multifocal HCC with the largest dimensions being 8.5 into 5.5 centimeters in predominantly in segments 6 and 7. There was portal vein tumor thrombus, which extended from right portal vein, left portal vein, extending to main portal vein, reaching almost up to the confluence, till the confluence. And it was VP4 of the classification. There were additional adrenal metastasis and lymph node metastasis seen as well. Here we can see there is a dilated portal vein and splenic vein because of the portal vein tumor thrombus, which and the ascites as well as this dilatation can are predictors are markers of portal hypertension. On endoscopy, which was done on the same night, 22nd of December, it revealed some small but high risk esophageal varices. There were post-EVL ulcers. There was mild portal hypertensive gastropathy and GOB2 type of varices, but there was no active leak seen. And then and there, a penicillin stent was placed. However, subsequently on the next day, it was seen that there was a further drop in hemoglobin and an ongoing melena. The hemoglobin dropped on 23rd from 6.6 grams to 4.9 grams. The AST/ALT were 417,132 on 24th of December. And next endoscopy was done, which showed GOB2 features with red color signs for which glue was injected. However, there was further deterioration with hypovolemic shock. Patient was on triple vasopressor support and hemodynamically unstable. There was liver failure and multiple blood transfusions had been provided. The MELS sodium score for the patient was 24 and it belonged to a CTP class of 9B. Because the bleeding was refractory to these endoscopic measures, with the falling hemoglobin and hemodynamic instability, a decision was made to move ahead with the rescue tips. But thing is, rescue tips in the case of portal vein tumor thrombus, which is extended up to the main portal vein, reaching almost to the confluence. And these were the parameters just prior to the procedure with a hemoglobin of 4.9, MELS sodium score of 24. With a high MELS score and extensive infiltrating HCC with extrahepatic disease, especially with the portal vein tumor thrombus, even though the patient was not an ideal candidate for TIPS, TIPS was performed with because it still provided the best survival benefit. The right jugular approach was taken. The root set was used to access into the right portal vein. Here we can see the portal puncture done, and the position was confirmed by the contrast injection, and the contrast run showed non-opacification of the main portal vein. As we can see, there is no opacification here, and contrast flush is seen within this right and main portal vein, which denotes the portal vein tumor thrombus. So further manipulation was done, and finally the TIPS parenchymal tract was dilated with a 10 into 40 mm balloon, and multiple catheters needed to be used to navigate through the portal vein tumor thrombus in order to reach beyond it, and negotiate the tumor thrombus so that we could reach the splenocortical portal confluence as seen here. Here we can see the portal vein tumor thrombus within the main portal vein. Finally, after negotiating the guide wire, the catheter was placed into the splenic vein and the contrast run was taken, and it showed opacification of the splenic vein with non-opacification of splenic vein near the hilum. However, near the confluence, there was non-opacification. So because of this portal vein tumor thrombus and this non-opacification, first angioplasty with a 10 into 40 balloon was done. Further, after which we can see no definite improvement in the opacification of the same. A measuring pigtail was then further used to measure the length of the tip stent to be used. And we can see the tip of the measuring pigtail to be in the superior mesenteric vein. And here is a part of the tumor thrombus which can be seen. This the other wire is within the splenic vein. This is the run. Coming to the after next the stent placement. Decision was taken that covered stents needs to be placed, which has to be a cover a long segment because of the portal vein tumor thrombus. A bare metal stent was not placed in the main in the area of the portal vein tumor thrombus. So therefore, a 10 into 120 12 centimeter means 10 into 120 and a 1080 covered stent were positioned from the hepatic vein up to the hepatic vein IVC junction, and the next is the main portal vein, and up to here. And further which the splenic vein, which was actually filling, that was covered with a bare metal stent. Here we can see the run taken from the splenic vein post the placement of the stents, which showed good opacification through this stent to the heart. Further which we needed to make sure the superior mesenteric vein would be able to drain into the confluence and into the portal vein. So therefore, we navigated through the struts of the struts of the stent placed. We navigated into the superior mesenteric vein and took a run to check whether the superior mesenteric vein is able to freely drain into the portal vein or not. So as we can see here, the contrast can be seen within the SMV, but however, there's no continuous flow of the contrast. So therefore, we could see that there is definitely a means it cannot easily drain into the portal vein. So addition was made that we need to also stent the superior mesenteric vein. So for the same, we first through the strut itself, a balloon mounted stent was placed. It was 8 into 3 centimeter, and was placed in the SMV across this narrow segment. Following which we took a run and checked the flow of contrast again, the flow of blood, and we can see that there is nice flow of contrast through the after placement of the stent. So after the procedure, the patient was followed up, and these are the parameters for the same. The patient had a hemoglobin of 4.9 on 24, and that was the day when we did it. Following which we can see there is a gradual trend of increasing hemoglobin levels, and there was no additional need for PRBG transfusions as well, with the graph showing the gradual increase. And also, since we are putting covered stent through and through to the hepatic vein IVC junction from the main portal vein, there is obviously a risk that are we compromising the liver supply? That is there any chance of liver failure? But here we can see that even the AST ALT levels have gradually decreased over time. One of the reasons is because since the portal vein tumor thrombus has been there for a long period of time. So therefore, there are multiple collaterals supplying the liver, and also the hepatic arterial system has taken over the liver hepatic supply. So therefore, there was no risk for deprivation of liver. There's no hepatic infarction or ischemia, and it was easily seen through the trend of AST/ALT levels. Bilirubin rose to 3.5 after the procedure and gradually decreased. That means the liver was getting used to the new hemodynamic conditions. So after the follow-up period, the patient was finally discharged. The procedure was done on 24th, and the patient was hemodynamically stable condition and was discharged with follow-up in OPD.
And because after the patient had tips, um, that he could now, since the even the portal hypertension has been also reduced, there was patient was even further taken up for the further management in terms of SBRT. The patient completed his full SBRT treatment from February 14 to March 3rd with no interruption and no hemorrhagical morbidity. And from our side, we also did an ultrasound on March as well, where we can see that there is a very good flow with the tip stent, even on the follow-up on March. And this month on 15th, we can see the chest X-ray. This shows the stent which we had placed, and minimal right-sided proliferation can be seen. However, there is no significant ascites when we check the patient on 16th, and the patient is doing well and going through further management for his HCC with no symptoms of portal hypertension as of now. So with this context on my case, I would like to add a few points to it. That is tips in the setting of HCC and portal vein tumor thrombus. There has been a lot of perceived risks because historically the fears of traversing a malignant thrombus, which would cause intra-procedure tumor rupture. It can cause catastrophic liver failure or any iatrogenic systemic metastasis. However, this has not been seen because of recent studies. The problem with this case is that these cases are very limited and a large study group cannot be found for that. Most of them are usually restricted to isolated case series or case presentations, and rather than a structured clinical practice. The technical difficulty is definitely the high pressure environment, which we can see in these cases. The access barriers, because with the type 4, especially in type 4 foot vein tumor thrombus, when even the supramesenteric vein is involved, there is even the splenic inflow often renders the standard tips ineffective. So we have to follow other routes such as transsplenic or transhepatic recanalization. And while operators usually try to route the shunt around the tumor mass, the shunt most directly traverses neoplastic tissue in approximately 6.3% cases, theoretically risking the tumor fragment. However, as we can see, one of the recent published journals, which I could find in the recent years, another one is in 2017, which had an even lesser sample size. In this journal, they found that there was no 0% extrahepatic spread or because of the placement of the stent, the covered stent across the tumor thrombus. They had a good, it is safe and effective for PVTT-related severe portal hypertension and a bridging therapy for hepatocellular carcinoma, which was seen in our case because it acted as a bridge through which the patient could receive further management. And there's a recent shift from the bare metal stents, as I said, to a PTFE covered stent grafts, which provides a barrier against the tumor ingrowth and drastically improves the patency rates. And the therapeutic bridge, as I have mentioned, is a hemodynamic reset because by controlling the variceal bleed and ascites, the tips allow the patient to survive long enough so that he can receive other adjuvant therapies, which include TACE, immunotherapy, or SBRT. And with saying this, I would like to come to the end of my case. Thank you.
Another, I think, challenging case in well managed government.
Actually, this was a very difficult case. So we always wanted to do, but this was the patient who once came to us. He was on triple ionotrope support. So we never thought he'll ever make it. And first thing what we did was counseling. Like, look, the cost would be high and we don't know whether the patient will survive or not. Somehow attendants were very keen. They said, whatever you can do, please go ahead. And the problem was when we started putting stent, we had to put 4 stents. And then he said, look, I'm spending too much. Are you sure that my patient is going to survive? So these are the dilemma when we actually treat, especially in Indian setting, when the patient has to pay from his side. Had I been in Europe, UK or US, there would have been no such thoughts because everything would be covered by insurance. So in India, we need to think like how patient is going to pay and what would be the outcome. But fortunately, what I thought, even if we get a 6 week survival, that is what we see in any kind of acute varicose bleed as per the guidelines by EASL, ASLD, APASL. But here I'm so happy that the patient has already received SBRT and still surviving and stent is patent. So the survival, what we think can be achieved only for HCC, that has been achieved with a VP4 tumor thrombus, which is extending up to the main portal vein. The patient is bleeding profusely, about to die. The first he survived of bleeding, and then now he is getting treatment for the tumor. And probably he may do well for at least 6 months, if not more. So those are the teachings. So, we got at least a year survival. I would like to have Dr. Chitranshu's
And
comment.
Dr. Amit.
challenging case. And actually, we do not have any option apart from doing this in this patient. Fortunately, the LFT was normal. The bilirubin at least was normal. In this patient, then tolerated the procedure. But this is happening.
I'm sorry, I missed a lot of it. But interesting, very interesting. I would agree that it can relieve the hypertension and infection. It's good because it has been used for normal thrombus as well. Nowadays, people do use transplant as well in patient with extensive total vein thrombosis in order to get a great protein flow and definitely increase the bleed and increase the recanalization rate during the function. The only point is because Amar made a point, so I thought what my understanding is in India you have been able to do this. In America, although there are insurance, but then this would have required a lot of political approval before this facility would have happened in America. Right? So it's India actually where you are able to do this type of right?
Yeah, please go. That's good.
That's a wonderful thought. In UK, I totally agree. What you say is absolutely right. That's a very conservative society. And I think even with level 1 RCT, they'll still think schedule, shall we do or not? Is absolutely. As far as the US is concerned, in US, there is no such challenges. And all such new things, new concepts are coming from US. PVR came from US. The first report about doing a tips in malignant PVTT came from US. So US is doing all those things. Yes, how they do it, that we need to learn from them. We'll see what kind of ethical clearance they take, what kind of, but they do. They are the first to show us the light. Although this was something which we did in a more aggressive way, but yes, maybe. But I think this is one thing which is taking us the science ahead. We should not always try to follow the West. Sometimes, East also may do something good.
Yeah, I think, lots of way we are way ahead. Like live donor liver transplantation. So, it's not a West procedure. It's an Indian, it's not Indian, it's an Asian procedure. And it has saved so many lives. So in terms of technology development, we're no less actually. Why I don't think why we keep thinking they are ahead of us. They're not ahead of us. It's just that we need to change our mindset that where we belong. That's what my feeling is.
Thank you.
That comes from after spending a lot of time in West.
Right. Thank you. Thank you, everyone. Thank you,
Thank you,
Amar,
sir.
for
Thank you.
very good cases, 3 good cases. Let's give him a big hand.